Hi everyone, I'm Patricia Greenberg, the Fitness Gourmet. Welcome to Eat Well, Live Well, Age Well. Well, according to the Arthritis Association, there are 54 million Americans with arthritis. Now, there are several types, but today we're going to focus on osteoarthritis. According to the CDC, by 2040, there's an estimated 78 million people who will be affected by osteoarthritis. U.S. adults age 18 or older are projected to have doctor-diagnosed arthritis, which means taking the guesswork out of it. A lot of people will get symptoms and say, well, maybe I have arthritis or something hurts or I'm at that age. We're talking about people going and having a bona fide diagnosis. Now, why is that important? Because the more you know, the better off you will be. Knowledge is power. I happen to be a member of that club, so this topic is very, very near and dear to me. Many people don't even know that they have arthritis. I do, just based on years and years of paying attention to my body, knowing what to look for, engaging in extreme athletics, and having done that for so many years, I start to understand changes in how my body feels. A lot of people just chalk off the pain as too much exercise, just being tired. I'm older. I can tell you I did the same thing for a number of years until I insisted that my doctor give me an MRI, and there it was, diagnosis of moderate to severe degenerative joint disease in my right hip. So I do experience pain almost daily. I've learned how to work through it, but my guest today is Mary Hale McDonald. She's been at this for a long time. I just give a little, her bio's huge, but I'm going to do a little run through because I'm so pleased to have somebody this experienced and educated. She's a bachelor's in exercise physiology. She worked in cardiac and pulmonary rehab for 5 years down at Duke University before moving over to UNC at Chapel Hill. And she's now certified by the American College of Sports Medicine as an inclusive fitness trainer, which she'll tell us a little bit about when she starts. Received a master's in epidemiology and a master's of public health in 2010 from the UNC Gillings School of Global Public Health Leadership program. She's now a presenter for ACE, which is the American Council on Exercise, and a contact tracer at Duke University during this pandemic. And her hardest job, in my opinion, is the mother of 2 children. So welcome, Mary. I'm so happy to have you here.
Thanks for having me.
Yeah. I want to ask you a little bit about we're going to start talking about arthritis, but tell me, what's an inclusive fitness trainer?
So the inclusive fitness trainer, way before it really became popular, the American College of Sports Medicine jumped on that. And basically what that is exercise for everyone. And by everyone, we mean people on the autism spectrum, people with intellectual disabilities, people with neuromuscular disorders, neurodegenerative disorders, basically anything outside of the so-called norm, which means very little. But we want to make sure that everybody can stay fit and healthy.
So let's start out by clarifying, what is arthritis?
So arthritis, just by mere definition, is inflammation and stiffness in the joints. But you got to remember that the joint itself isn't just 2 bones articulating together. You know, there's a lot going on in there. There's cartilage, which, contrary to popular belief, really doesn't have much of a bone or blood supply. It doesn't regenerate. You've got ligaments, you've got synovial membranes, you have the joint space with some of its own fluid in there. So when you talk about inflammation of a joint, we're talking about inflammation of many things.
So the whole area becomes affected.
You got it. Yep.
So arthritis can be more of a catch-all term for several things going on in the area, or is it related strictly to the bone?
Arthritis is actually related strictly to the bone. What a lot of people don't know is that bones are not merely the structure for our body. That is their primary purpose, but the bone itself is very much alive. It has a skin called the periosteum. And so the ends of the bones that articulate with one another can actually be worn down over time. And it's not just wear and tear. That's contrary again to popular belief. It's, what that sort of elicits in our mind is that if you use it, you're going to lose it. And that's not the case. It's really about repetitive motion that tends to be very high impact, and what that does to the surface of the bone and what it does to the surrounding tissues. Everything sort of stems from the bone.
Now, I know there's several types which we're going to touch on today, but I want you to come back and continue to have this discussion about all the different
Sure.
types of arthritis. So we're going to have a long, healthy relationship, Mary, talking about this.
Fabulous.
We have a aging population, and I think it's just going to end up being a bottomless pit of discussion about how to manage this as we age. But what are the first indicators of arthritis?
Usually the first indicators are, pain where there wasn't any. When you're doing activities that you're very familiar with. I mean, even something as simple as walking, but it's generally when you're participating in whatever your sport is. And remember too, that if you're a couch potato, that's your sport, and you can develop issues with that. We can go into that another time, but,
Okay.
with the early signs of arthritis, it's usually just pain and inflammation in an area, slight swelling, generally very predictable though. You know what's going to cause that. And
Right.
so the tendency there is to avoid it, to manage pain.
So just kind of want to go in sequence. So we avoid activities that cause pain without really being aware of what's causing the pain. It's just, that's where it starts, where people say, well, it hurts when I go running, so I'm not going to go running anymore. Or it hurts when I jump up and
Right.
down. Okay. So what is the age group you tend to see the osteoarthritis in?
Me personally, the age group that I see is generally over 55.
Okay.
I'm not saying that I don't see the early onset stuff. We definitely do, but I'm not as much of a sport specific trainer as I am really an exercise physiologist.
Okay.
I've been a trainer for 20 years, but I tend to work with an older population and with a quote unquote damaged population, that have some compromised joints. And my job is to teach you how to live with that and how to move and be able to do it with as little discomfort as possible.
What is your starting point when somebody comes to you wanting help on managing the arthritis? Maybe even more basic. Do people come to you before they even know it? There's pain or there's discomfort or they're figuring out how to adjust their workout even before they've gotten the diagnosis? Yeah.
All of the above.
Yeah.
I would say there's multiple answers to that question. Number one, a lot of people, at least in the area that I live in, I'm in the South, and we're, in a big college town, and you get a lot of academics here who understand that, prevention is key. Prevention's cheap. It is so much easier to invest in your wellness and your health than it is to pay the hospital bills later on. So you've got a lot of fit people around here who pay really close attention to their body. And when something goes awry, they have a tendency to go to their medical fitness center or their gym and talk to an exercise professional. Like, what do you think this is? And, most of the time we see you more than your physicians do. Right. Especially if you're a member in a place like that. So that's a good, reliable source. Those are health professionals too. But it also comes down to once, especially if I'm starting to work with somebody who is very well, their joints are fine, but you stick with somebody for 10 years and things change.
Yeah. Yeah.
Yes. And often we're like, hey, maybe you should go get some baseline x-rays here and see if it's the kind of pain that you're describing. You've had it for months and whatnot now, and nothing is really seemingly getting rid of that. Then let's talk to your physician about the possibility of an MRI and just take a look at what the soft tissue looks like too.
Yeah, so then someone has the diagnosis or beginning stages of arthritis. I guess the thing that I want to break down the different body parts. What I'm still, full disclosure, like I said, I'm in that club, fortunately or unfortunately. What happened to me was I was running for 25 years and I started to have the last couple of years a lot of pain, and I went to the doctor and they said, oh, you probably have bursitis and you probably overtraining, cut back. And I said, starts to hurt around 4 or 5 miles. And the doctor said, well, then just stop running, go for 4 miles, don't go any further. It took a couple of years for me to actually get an MRI, and bingo, there it was. And it was in my hip. And I was told there's nothing we can do, just take Advil and walk instead of run. So we want to talk about that going further, that for some people that feels like a death sentence.
Absolutely.
And I know there's ways around it. So why Why does arthritis hurt? This is kind of the mechanics of it. Is it out of place joints, exposed bones, inflamed tissue? I know it's all those things, but what's actually causing the pain?
So the pain is actually caused by the inflammation. Inflammation generally throughout the body is what causes pain. It alerts our nervous system, to process that pain.
Okay.
In this case, let's just talk about the knee, or in your case, since we were talking about hips, let's talk about the hip.
Okay.
Hip is extremely weight bearing, and the end of the bone, or the acetabulum, that round part that kind of goes into the pelvis. If you think about the upper part of our body, everything above that line is the majority of our body weight as well, and it's sitting on this little ball. And the top of it, where it's articulating with the inside of that joint, gets broken down, becomes more porous. You start developing some bone spurs as the surfaces grind together and the cartilage wears down. The body is always trying to remodel and repair. But in a case like that, especially where you're constantly beating on it, the remodeling can kind of go awry, and you get some bone spurs and you have some sclerotic tissue, or really hardening of that cartilage. And there are two substances that do not regenerate in your body. Cartilage is one of them, and enamel on your teeth.
Yeah.
And, so the cartilage is not going to replace itself. The other thing is that your synovial membranes, what produces all of the lubrication for your joints, go haywire, and they think, hey, this is uneven in here. I'm going to produce more lubrication. And so you get this swelling of the joint itself. It just gets huge. So the pain is like, it's not only from inflammation from all of those very live tissues in there, but it's also putting so much fluid into a place that doesn't really have room for all that fluid. Right. And that deadly combination there is what causes the discomfort.
And that actually will, in some cases, people have to be drained, right? I was going to say that the level of liquid is almost dangerous to have that amount of liquid in your system. What body part is affected the most?
By and large, hips and knees.
It's hips and knees. Okay.
Those are the top two, followed pretty closely by the spine.
So I know people are getting hip replacements, like it's becoming very, very routine, both hip and knee replacements. And I keep hearing that knee replacements are, in most cases, 100% successful, meaning people can get up and go back on with their lives. Hips are a little more hard to manage. Yes? No? I'm curious.
No. Okay. There's some truth to all of that. It really depends. Let me say this. The only caveat to that is that anecdotal evidence from just 20 years of seeing it, a lot of orthopedic surgeons really wait an exorbitant amount of time to do the surgery. And I understand why they do that, because the replacements only last a certain number of years, maybe 15, especially if you're still really active. And you got to think that the replacements are going to change and improve over time. Right. So if you have a replacement at 50 and, at 65, you need another one, you're still young.
Yeah.
You may need another one at 80. And what they have to do is give you the same model that you had, even if the technology has improved, because they don't always change. Right. So let's use the knee as an example. Years ago, when I got out of college, when they did a knee replacement, they just opened up the knee, chopped out the femur and the tibia and the fibula, and they took the whole joint out and replaced it with an artificial one. Now, knee replacements are nothing like that. They cut off the end of the long bones. They just put a new cap in, and they spare all your soft tissue.
Okay.
They can't do that if it's not there. So oftentimes they wait too long to do the surgery. And so there's a lot of physiological damage. Legs start to bow, and a lot of muscle atrophy, and you've just got a terrible mess. And you wait for something like hips and knees too long, and it starts to affect other joints.
Yes.
Where you develop arthritis, everything above it and below it. So the hips, though, the new method of replacing hips is to go in anteriorly on the front part of the leg, where they don't have to cut through any muscle. They don't have to snap anything. So we've got people that have had a hip replacement 2 days ago, and are up and on an elliptical trainer, and they're good to go.
Amazing. What I want to talk about the long-term goals of managing it. But first of all, I think this is kind of the bad news, is that it's a little arbitrary on who and where it hits.
That's right.
I did a lot of research before I got on with you today, and I see that there are people who can, I always, what I call myself as a mid-packer. I wasn't fast, I wasn't slow, and I never ran 70 or 100 miles a week.
Right.
I was always the 30 to 40 when I was marathon training, and then cut back to 15 to 20 on the down weeks. And I still got it. So, and I have friends, I'm sure like me, hundreds of people, if not thousands, that are running marathons in their 70s.
Absolutely.
So we don't know why it hits people to the degree that it does. But is there any pattern that you see in terms of prevention, that you see people, there's any common threads in people who are very fit and athletic and get it?
Absolutely. Prior injuries, that's going to be the number one. If you were an active kid, and generally speaking, the most active and agile, right, are the youth.
Yes.
And a lot of us were, wild women or wild men, when we were younger, jumping out of trees and whatnot. So you think about some injuries that you had as a kid, definitely are precursors for osteoarthritis, probably the number one. There is genetic component, but the other thing too, to a trained eye, you've got people who have got biomechanic issues, that just by virtue of being born to the two parents that you have,
Right.
Bowed legs, pigeon toe, you name it. Lordosis, which is just the standing to the side and your butt sticks out a little bit further, kind of walking like foghorn leghorn, that kind of thing.
Mm-hmm.
So biomechanical issues, which are no fault of anybody's and generally out of your control, are also a precursor because it affects the way the joints align. But largely, it's the injury. It's the prior injury.
Okay, $1 million question. Does anyone anywhere ever have they reversed their arthritis?
No. We can halt progression sometimes, especially when you're talking about when you catch it early and you're aware that something's going on. If you're participating in whatever your sport is, for you it was running.
Yeah.
Somebody could have potentially intervened at that point and really gone over what we call the PNF patterns, or the proprioceptive neuromuscular facilitation patterns of exercise that basically just include, flexion, extension of a joint, abduction and adduction of a joint, and then internal and external rotation, so that your joints are used to moving in all three planes of motion and they're comfortable doing it. And it's good range of motion.
Right.
And so you can anticipate, a change in ground, a change in terrain, and manipulate that a little bit better and really avoid the injury in the first place.
Yeah, well,
so no cure.
No cure, but that's exactly what my next question was. Does physical therapy stave off further decline? So I guess there's ways to do that if you find it at a point. Now, is it inevitable that it will just get worse?
Generally speaking, yes, it is a progressive disease. Depending on where it is, and it definitely determines how manageable it's going to be. If you've got weight-bearing joints, and we're talking about, bones of the feet, ankles, knees, hips, spine,
right?
Those are going to progress a little faster because you're weight-bearing, and unless you are willing, and I really don't know many people that are, to just completely stop all physical activity, which causes a slew of other problems.
That's right.
And not recommended at all. Then there's no way to avoid that. But there's ways to make movement purposeful and a little bit more manageable, where you're not killing your joints. You're, using them really in a much more neutral way. But something like your hands, elbows, shoulders, where they're not necessarily, they're not weight-bearing joints. That's where, tennis players, pitchers, swimmers, very repetitive motion. Even factory workers and chefs. You and I are both.
Yes.
Yeah, you think about what it does to your wrist and your hands and, your shoulders over time when you're chopping everything and stirring heavy things. And it's wonderful, but those tend to move a little bit slower in progression.
What are the lifestyle modifications that you recommend? Someone comes in, they're newly diagnosed. What's step one? What's the first thing?
For me, it's really all about information gathering. I want to know, what is it that you're currently doing? What is it that you are absolutely unwilling to part with? And is there a way that we can manage this disease so that you can still participate in those things? And if you are willing to modify it a little bit, like for instance, if you were a runner and running is just out of the question at the moment, is it possible to move you to something like cycling, where it's a bit more predictable for the joints? You're following the same elliptical pattern constantly. It's much less weight bearing and much less impact on the joints. You are still outside. You are still able to see the scenery and get that, rush. That's what I've had to do is go to cycling. So really the information gathering is the first thing. And then also, if there isn't a strength training component put in there, I want to know, well, A, why not? And are you willing to add that in there so that we can really strengthen the muscles around the joints and make life a little bit easier for you?
I think, Mary, you're going to have to clone yourself across the country, because I'm guilty of what many athletic people do is you don't think about it, you just go running. And when you're training for a distance, you just keep making your way towards that distance.
Yep.
Cycling feels like, oh, I only cycled 3 miles. Let me cycle 12. Let me cycle 24. Let me cycle 100. Like with anything. Oh, I playing 1 round of tennis feels good. Let me play 10. You know that. I don't have to tell you.
Yep.
All. So none of us go in feeling like, okay, let's discuss our range of motion and how we're going to,
right.
And all you hear is that, well, trail running is good because it makes you use every part of your body differently and so forth. So what's your magic formula of movement that helps people with arthritis?
I wish there was a magic formula. I wish it was that simple. It's really just taking a look at each individual person is individual, and treating every person as if they are a completely different machine than you have ever seen before. And that's the key. Right. Looking at everybody, doing functional movement screenings on your client. Can they squat? Look at them from every direction. Are their knees coming together? Are they pronating at the feet? Watch them walk. Right. What do their feet look like? What are their legs doing? Are they swinging their arms? If they're not, that can be a sign of a neuromuscular disorder or a neurodegenerative disorder like Parkinson's.
Interesting. Wow.
Yes, there's lots of, it's really just watching your people move. Talk to them about injuries that they've had. And then after you've done those screenings and you've identified where are the muscular imbalances, where are their biomechanical issues, if there's, are these things that we can correct? And if they are, and it seems that it is just strictly muscular, get a good, base strength program going on. A lot of times, most of the people I see have not exercised in years. Okay. So I start with really big muscle groups and kind of broadly strengthen, and then we start getting very specific as we go. But
what is the compliance rate of people who come to see you? I know you're in an environment that wellness is appreciated. But in general, what is the compliance rate of arthritis patients who are willing to step up to the plate and do what's necessary to keep the joint strong in the area where they're experiencing the arthritis strong?
I find, at least with my own clients, extremely high. Once I have some clients I've been working where I'm currently working, UNC Wellness Centers. I've been there 16 years. Okay. And I have clients I have seen for 16 years.
Wow.
That we've aged together, and we've dealt with our joint problems and whatnot together. So I find that they're very compliant, especially if you can show them how successful they can be. And that you've managed their pain and they're not having it anymore, and they are still able to hike Machu Picchu or whatever it is they want to do.
Right. Good goal. Yeah. Machu Picchu is a great goal with someone.
Good goal.
Anybody at any age. It's a great bucket list goal.
Yes.
Any foods that you can recommend, best and worst?
I find it interesting that one of the top over-the-counter, treatments, like topical analgesic, really for arthritis, has capsicum, right, or capsaicin, and yet eating that in hot peppers and some of the foods that actually carry that can be an irritant. So it's kind of funny. I'm not a nutritionist and generally don't. I usually leave that stuff to you nutrition professionals.
Yes.
I will say that in my scope of practice and within my scope of practice, I think the most important thing is hydration.
Okay.
You know, our bodies are largely, you know, over 90% water. And if you think about the lubrication for your joints is also comprised of water, number one. And your muscles operate on electrolytes. So if you do not have a diet that is rich in calcium, magnesium, sodium, potassium, which every single muscle in your body uses to contract and relax. You know, I live in the South, any exercise out here from about April through November, it is hot.
Yes.
You're sweating, we are losing salt. If you can taste the salt on your face, you need to replace it. Water isn't going to cut it. So if you're not replacing those electrolytes, you are going to have muscular imbalances. You're going to get cramping. And over time, that can cause some damage.
Yes. Yeah. Good to know. Yeah. And that's something I always recommend is fruit every day, vegetables every day, and lots of water. Even if whatever else you're having, just make sure it's there. But I just was wondering if you came across anything interesting, but it's very, very interesting what you're saying about the topicals. And Advil is
Advil, naproxen, Tylenol, you know, Tylenol, especially if you have got heart disease.
okay.
A lot of times some of the NSAIDs or the non-steroidal anti-inflammatories do not bode well with heart medication. Okay. Always talk to your pharmacist or your physician before you start any of those things. You know, I'm a big fan of BioFreeze, and which is a lot of massage therapists use it. It's a great topical. It is really non-medicinal. It's just it's got menthol and it's wonderful. It cools and heats at the same time, so that's a really good one. But your doctor can prescribe things like Voltaren gel, which is like essentially an Advil that you rub on your skin, and some people find that extremely successful. Find that very helpful.
I think that's moved over now to over the counter.
I think it has. Maybe it has.
It has. So very accessible.
Okay.
Yep. Very effective. Yes. Excellent. I'm a big BioFreeze fan also. So it's funny.
Love it.
So Mary, I wanted to move over just for a few minutes. We're not running out of time, but I don't want to belabor anything too long. Quick, can you differentiate between osteoarthritis, which is known as OA, and RA, which is rheumatoid arthritis?
Absolutely. Okay. So they are very, very different. Osteoarthritis is not autoimmune.
Okay.
It is basically, you know, the wear and tear in the joints. Now, I said in the beginning, you know, it's not just normal wear and tear. It's overuse, right, and being overused in essentially the wrong way. Rheumatoid arthritis is something entirely different. That is autoimmune. We do not know what the impetus is. We don't know what starts it. We don't know why the body starts to attack itself. And there actually are serum markers in the blood that are used to identify that. The RA factor, the SED rate, and that is essentially a marker of your joint breaking down. You can become, for lack of a better term, really, it can deform joints.
Okay.
And, but, you know, there are several types of RA under that umbrella as well, and some of them even affect your organs.
Okay.
So it's a different ballgame altogether.
So that's why it's critical. Mary and I are going to tell you this together, is go to the doctor and get a diagnosis and get these tests. That's part of preventive medicine, is just going out, yes, just getting your baseline, find out what, you know, where you're at right now, and then you can detect any changes. One thing I always say, it's really best to catch anything in the beginning, regardless Agreed. Of what it is, and you can get a handle on it. Mary, you do telemed appointments?
I do.
Did you want to share your contact information so we can?
Sure. So I have two email addresses. One goes directly to UNC, which is mary.hale, Hale, at unchealth.unc.edu, or a Google email, which is just mary.petters, Petters, at gmail.com.
Okay, and we'll post those at the end of the show. Mary, I'm so happy to talk to you about all these things. It's not the most pleasant subject for people, but, you know, being informed and being aware is really the best way to go for yourself as well. So let's trudge on and continue to, I don't even want to call it fighting a fight, just continue to provide, you know, care, information and support for people who are going through this, because you don't have to be miserable.
No,
There's so many ways to make yourself feel better, and just embrace it, accept it, and get the help you need. That's what we both feel very strongly about. So Mary, thank you so, so much for joining us today.
thank you again for having me.
I just so wonderful to see you, and we'll see you back again soon, I'm sure.
Absolutely. Thanks a lot.
Thank you.